Good afternoon, everybody. I Dr. Souren Paja, on behalf of ISCCM Kolkata as General Secretary, welcome you in the third session of our this COVID-related webinar. And today we have with us, our Dr. Amitabh Saha. He is our treasurer, ISCCM Kolkata branch, as well as senior consultant in critical care and medicine department, Medica Super Speciality Hospital, Kolkata. So Amitabh is very known face to all of us. He will moderate the session today, and along with that, there are two speakers. Dr. Asif Iqbal, he is the senior consultant in chest and critical care medicine, Apollo Gleneagles Hospital, and he will cover topic that is one of the important topic, because we have a lot of doubt about the antiviral therapy, what medications we should give and which one we should not give. So for that, there are so many literature as well as published articles has been published in the last couple of months. So what is the current status and how can we apply all those one particular antiviral therapy over and above other antiviral? So there are merit, demerits as well as availability of the drugs in India. So those things we have to consider. But what is the current evidence in the antiviral therapy armamentarium? Along with that, we have our another speaker, Dr. Binod Kumar Singh. So Dr. Binod Kumar Singh was my colleague for about 8 years in Sir Gangaram Hospital. He is senior consultant as well as the academic coordinator in the Department of Critical Care and Emergency Medicine in Sir Gangaram Hospital. And that Sir Gangaram Hospital is also one of the prime hospital that is treating the COVID patients, and there are almost 300, more than practically 300 beds. There are 3 hospitals under Dr. Sir Gangaram Hospital. So there are more than almost 125 to 30 patients in the critical care unit, and along with that there are 200 patients non-COVID. So that is one of the very large hospital, and sir has enough experience on the convalescent plasma therapy. As we know, that in Maharashtra and Delhi government, they first basically started that plasma therapy, and they had also asked that doctors to use the convalescent plasma for plasma therapy. So sir will highlight this, and along with that we have relatively he will share the experience about the convalescent plasma therapy. And with this, I will request Dr. Amitabh. I will hand over to Dr. Amitabh to take the session as well as to moderate. And then after that, Dr. Ahsan will be there for the vote of thanks. He has not joined till now. I think he will join in short while. Okay, Dr. Amitabh, please.
Yeah, thank you, Sholenda. This is a pleasure for me to moderating this session. There are 2 important speakers with us today. Dr. Asif Iqbal and Sir is there, Dr. Binod Singh. So Dr. Asif Iqbal has a huge experience, as all we know that COVID infections, the virus is a very fine virus. Sometimes the antibacterial like azithromycin is acting against it. Sometimes the anti-inflammatory HCQS is acting against it, and obviously the virus, as we have some experience with Ebola and MERS-CoV. So taking these experiences, we are using so far some antivirals with this COVID infection, but we really didn't get any a huge advantage of using all these antivirals. And now the new antivirals are also coming into a clinical area. So I would request Dr. Asif Iqbal to highlight all the antivirals that is available and how can we go about it, as we have experienced last 2-3 months of managing COVID infections, and we have also gathered some information and some experience of using the antivirals, different antivirals in some of our patients. So I am sure that Dr. Iqbal will definitely do justice with his talk. Dr. Iqbal, please.
Thank you. Thank you, and very good evening to everybody. Because COVID is a pandemic now, and it is a very important health-related issue. And not only the health-related issue, it is a huge economic burden for the family and the country and world also. So we all are waiting for the proper drugs, proper vaccine, and 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 we want to survive with the COVID. So let us start with the data which till date we have. What are the antiviral agent right now? There are a lot of trial is going on regarding the different retroviral on the different retroviral drugs and other medication. So let's see what literature support. So start. Yeah. So we all know that from the January, this disease has appeared in the China. Then it entire globe is involved, and from the month of February, we have started to experiment with the different antiviral and different drugs, and this is the first FDA approved in this is FDA approved the seventh. This is the there are a lot of drug on the trial, and FDA approved. There are only one drug for the COVID trial. That is initially they have tried with the ritonavir and lopinavir is an antiretroviral drug. It is work on the RNA virus. Then there is a remdesivir. Then there is a flavivir, and also the hydroxychloroquine and lot. But now the latest report suggesting these are the drugs which is rightly using in the COVID in the different country, and but this is the remdesivir, this is ritonavir, lopinavir, hydroxychloroquine, ascorbic acid, chloroquine, and also the ivermectin. But now the trial is giving some report. On the basis of that, we are concise our practice two to three agent right now. Among that, the 7th May in 2020, Japan approved the remdesivir. Also in the May, FDA also approved this remdesivir, and it has a hope, but there is a two contradictory report coming in the two trial. One is the trial going on the NIH's clinical trial, so remdesivir accelerated recovery from the advanced COVID-19. At the same time, the Lancet has published that the remdesivir in adult severe COVID-19 randomized double-blind placebo-controlled trial showing that it is not very effective. So whether it is a whiff or whether it is a reality, so let's see what the drug is all over. So first thing is that remdesivir, it is first approved in the FDA in the month of May. Subsequently, Japan also approved. And what is remdesivir? It is a novel nucleotide analog. It is a product. It is a ribonucleotide analog. It is a product and it is directly acting on the RNA chain terminator, and it is delayed the terminator, and it's a broad spectrum. It also have effect on the several RNA virus. So how it's work? It is a remdesivir is a product. It has a C nucleotide. It is resistant to ribosylation. That is the resistant mechanism of the RNA virus. And there is one prime cyano group that is also is increase the potency regarding the RNA viruses. And there is another chain that is called McGulen proteid product. The purpose initially, it increased the cell permeability. It helped to enter the cell. The permeability of the drug has increased, and it can also enhance the organ specificity by capitalizing the expansion of the bioavailability enzyme. So this is the pro drug. When it enters the body, it first hydrolyzes. Then there is a kinase enzyme which cleaves the molecule and produce the active molecule, that is GS for 441524 triophosphate, which inhibit the viral RNA synthesis. So this is the process by which it works. The plasma half-life of the remdesivir is 20 minutes. Adverse effect: it decreases the blood count, it metabolizes in the liver, so it increases the liver enzyme, and also it has an effect on the, it decreases the albumin and potassium by renal excretion of the potassium. The doses is 200 milligram IV first day, then 100 milligram once a day for 5 to 10 days, depending upon the severity of the patient, and it is recommended for moderate to severe disease. And if there is a liver enzyme is higher, more than 5 times the normal, then you can't use this drug. And if the EGFR or creatinine clearance less than 30, then you can't use this drug. So what Lancet published in the month of April, they have published this remdesivir adult with severe COVID-19 double-blind placebo-controlled multi-center trial, and they published this data in the month of May, and it's showing that though it is a effect on the SARS-CoV-2 virus, but it is not very much effective in the severe cases. But it is good for the data suggesting that it is good for the moderate to moderate disease, but not very much effective on the severe disease, and it is not effectively reduce the viral load very efficiently. But subsequently there are a lot of trial going on, and this is the article from the NEGM. It is compensated use of the remdesivir for the patient with severe COVID-19. That is also showing that opposite. This is showing that very positive trial, and it has been shown that the number of patients in oxygen support after the treatment percentage, it is showing that it is sufficiently reduced the oxygen requirement among the severe disease COVID-19 patient. And this study is showing that there is if the patient is in a non-invasive ventilator, they have much better result than those who are in the invasive ventilator. And also showing that this is the very interesting fact that remdesivir is the incidence of clinical improvement. It is showing that those who are the lower age group, like the highest success rate among those who are less than 50 years of age, and between 50 to 70 there is a moderate response, and more than 70-year age there is a not very much response with the remdesivir. Though in this article they have not explained properly whether age and comorbidity is the criteria for that. They have only said that need subsequent trial to know why the age factor is there. And in conclusion, that showing that in a severe disease patient, they have a 68% patient who has a reduced oxygen requirement after 5 to 10 days of treatment. Then another drug is lopinavir, ritonavir. It is a retroviral drug. It is a combination with ritonavir, lopinavir, because they have a volume distribution, protein binding, and the more similar, and the half life also quite similar. But the interesting fact is that when you are giving combination the lopinavir along with the ritonavir, it increase the bioavailability, and also the both the drug, its concentration in the tissue level has increased due to reduce the metabolism. Lopinavir reduce the metabolism of the ritonavir by CYP3A4 inhibition. So, and lopinavir, ritonavir, there are literature supporting that this drug is reduce the replication of RNA virus. How the COVID SARS-CoV-2 virus work? They enter in the cell, then they proliferate, they then rupture the cell membrane and kill the cell. So that, and they produce the lot of inflammatory mediator, and which subsequently increase the cytotoxin storm. They created imbalance between the pro-inflammatory and the anti-inflammatory. And how the lopinavir, ritonavir work? They also enter the cell, and they bind the RNA chain, RNA ribonucleic acid chain, and they prevent the replication by binding the chymotrypsin link protein, 3CL protein, and they prevent the replication of the virus. So they ultimately reduce the cell death. But the subsequent study is not very supporting that lopinavir is very much effective. The trial of lopinavir, ritonavir, it is also published in the May 7, 2020, and it's showing that in severe cases it is not reduce the viral load, and it is not very effective to reduce the prevent the cytotoxin storm, and but it has a very hepatotoxic and it increase the liver enzyme manifold. So the in meanwhile the trial has stopped due to the liver failure of this patient, maximum patient. So this trial showing that in the placebo and the lopinavir, there is no very significant result, and also shown that there is a mean changes from the baseline SARS-CoV-2 viral RNA load is not it is as comparable with the placebo. So they have published that the in-hospital patient with severe COVID-19, there is no benefit observed in lopinavir, ritonavir treatment beyond standard care. Next, and this is the subsequent another trial also showing that there is a current no strong evidence to efficacy of the lopinavir, ritonavir for the COVID-19. Though there are many places they're still using the lopinavir, ritonavir. And then there is a come of flavipiravir. That flavipiravir also inhibit the RNA polymerase, and it is already used for there are few Asian country for treatment of the influenza and influenza like illness. And flavipiravir, it also inhibit the RNA polymerization, and there are 2-3 trials is showing that that's mild to moderate COVID-19 it is effective. But there is a debate is going on whether we use this one or not. And the advantage of the lopinavir, ritonavir, it is available in the orally, and for mild symptomatic patients the large trial is going on still it is on the trial drug, so we can't definitely say that this is a very good effective drug. The time will tell us. And there are other drugs which actually not antiviral drug, but they have antiviral property like hydroxychloroquine for prevention of the COVID-19. And there is also the research is going on the hydroxychloroquine, and it has been shown that hydroxychloroquine has some effect to reduce the replication of the SARS-CoV virus 2, though there is a negative trial also proved that the some school saying that hydroxychloroquine is not effective for the COVID-19 patient. And whether it is used for we will use for prophylaxis or we will use for treatment, there again the controversy is going on. But still hydroxychloroquine is little, if we are finding that it has some effect. Those, especially those patients, it is our own experience for last 3 months that we have treated almost thousand patients for screening and the treatment. So we are found that those patients who have the hydroxychloroquine prophylaxis, which, those the healthcare worker, they have a hydroxychloroquine prophylaxis dosage. They have very mild symptomatic. If they are infected, the number is very less for our healthcare worker, and those who are in the prophylaxis doses, they have a very mild disease. So much more trial needed, larger trial needed to prove whether it is effective for prophylaxis. I think ICMR is doing this trial. And there is another drug that's ivermectin. It's also have the, and there is a also have antiviral property, but that most of the literature is not supporting. So right now take home message is our hand is remdesivir, having some prospectus for the preventing this disease if we use earlier. It's just 1 month ago this drug is available in India. We are using and we are collecting data. Hopefully, in India, we'll have good amount of data on the remdesivir and flavipiravir. So let's see what the future will guide us. Thank you for patience hearing.
Thank you, Asif, for the nice presentations. Your presentation has actually given a lot of answers to us, and I'm sure the people who have joined our webinar are also getting much of benefits after listening your lectures. So I would request all the participants here to put your questions into the forum so that we can get your questions early and can answer at the end of the session. So I would like to put one comment regarding the remdesivir is the remdesivir, the trial that has been done in the NEGM. It has been shown that maximum beneficial effect, that the durations of the disease process has reduced down in the group 4 and 5. That means they have actually made the severity of 0 to 10. 10 is the death and 0 is the outpatient, and they have received the maximum benefit at the group of 4 and 5 where the oxygen requirement is there. But once the patient is going to HFNO, that means the higher oxygen requirement, the benefit is much not there. So we really have questions where actually we need to apply the remdesivir, and how early and which is the group of patients who will be getting the maximum benefit, as the availability of the remdesivir is much low at this point of time. So we have to be cautious and judicial of using remdesivir so that we can actually get the maximum benefit and pass on the benefits of using the new antiviral to our beloved patients. Uh, so, saying that, I'm just going to the next level of what are the other modalities of our patients uh, of infected with the COVID, they can get benefit of some of the off-label uses of the convalescent plasma. They are coming into a big way into the clinical areas, and Sir has actually used a lot of plasma till date. He has the maximum first-hand experience. The day before yesterday, we have also received the permissions of using the plasma from in our hospital. We have already started collecting plasma in different blood groups. So I am sure that after listening, Sir, I am getting some informations, more informations, and will be more confident to use this. So, Sir, I would like to request you to start your presentation, please.
Just trying to share.
Sir, will you just share your screen once?
No, I present on the slide. Okay. Just trying to load here. It's taking some time to load it.
Yes, sir.
While my file is getting loaded, I must thank to Dr. Saha for nice introduction, and my sincere thanks to the ISCCM Kolkata for inviting me to talk on the plasma therapy. And okay, so it's nice to be in the part of webinar of the Kolkata ICCM. And what I'm going to talk about the convalescent plasma therapy in COVID-19, the current status and our experiences. Now, we must accept that the SARS-CoV-2 has put all the planet and humanity on a battlefield. Now there is a race against the time to find a treatment to save the life and to find the solution to save the humanity. And as told by my previous speaker, that there are several drugs, some are under investigations, some are getting more controversy than the answer. And so the convalescent plasma, again, it is not a new treatment for any infection, it is an old treatment, and it has found some role in the treatment for the COVID-19 or COVID-19 disease. Now, what I'm going to talk about the evidence that convalescent plasma might be beneficial in COVID-19. What is the current scenario? What is our experiences, and what are the challenges we are facing in managing such patients with COVID-19 with the convalescent plasma? Now, the World Health Organization estimates that the serious illness may occur in as many as 13.8% of cases, and about 6% or 6.1% are very critical needs admission to the ICU and the ventilation or some type of organ support. And the search for effective treatment is underway with the multiple investigations ongoing across the world. Convalescent plasma or CP emerges as one of the options for the management of hospitalized patients with COVID-19, and neutralizing the antibody, which the patient antibody helps to control the COVID-19 infections and modulate the inflammatory response in such patients, particularly if they are moderate to severe. Now, if you look at this, we can find out there are several presentations presenting from the asymptomatic patient up to going to the cytokine strong, the patient can go for hyperinflammatory response or cytokine strong, the patient can go for a pathogenic coagulation, and the patient can go for a hyperactivation of the endothelium and can cause a massive coagulation. These are the present and stable pathophysiological features of the COVID-19 disease, which can lead to severity and increased mortality in patient COVID-19. Now, what is plasma? We all know that in our MBBS time, we have been taught many times that the plasma is the liquid portion of the blood. If you centrifuge the blood, the lowermost portion is the RBC, and then you have a buffy coat of the WBC, and then finally we have a liquid yellow portion, which is plasma. Just for remembrance. So the convalescent plasma is the plasma is separated from the whole blood of the recovered patient, and this is called convalescent plasma. This contains antibody against the COVID-19. Now, what we are actually doing, look at this diagram. A patient who has suffered from COVID-19, after 14 days or some time, the patient gets recovered. One of the impact factor for the recovery of the patient is formation of the viral neutralizing antibody in this type of patient who has recovered. Now, what we do, we utilizes this viral neutralizing antibody and we inject this serum or the plasma to the two types of patient. One, we can use it for the prophylaxis who has got a COVID-19 exposure, and other which can use as a therapeutic purpose for a patient who has moderate to severely ill with the COVID-19. So basically, in the plasma, we are utilizing the neutralizing antibody. Now, this is very important that we should understand the therapeutic window of the COVID-19. Now, we have seen that the patients comes under two phases, mostly what we see. The first phase is those who are within first week of their symptoms. And in such type of patient, you will find that patient has got no much desaturation, there is no much inflammatory response, but the viremia is at the peak level in the first week. And sometimes very less number of patients will have happy hypoxia. But once from here the patient can improve also. But some percentage of patients might land up in the second week in a severe inflammatory response. You can see here that the patient might go up to the hyperinflammatory response or cytokine storm leading to ARDS and shock and viral sepsis. And here the most important factor is that the decrease in the oxygen saturation. Now, if you look at this pathophysiology, we can think that if somebody wants to treat the patient with the convalescent plasma, we have to start somewhere here, because when the patient is a very high viremic load, once the patient has gone to uncontrolled inflammation or the patient has gone to a cytokine storm, probably the convalescent plasma has not got role in such situation. So therapeutic window, or judging the therapeutic window to have a therapeutic impact of convalescent plasma on such patients is very, very important. So if you look at the mechanism of action, how convalescent plasma acts, the antibodies from the convalescent plasma might suppress the viremia, which is very important for action or for clearance of the viruses. And viremia peaks in the first week of infection in most viral illness. The patient usually develops a primary immune response by days 10 to 14, which is followed by a virus clearance. Therefore, theoretically, as I told, it should be more effective to administer the convalescent plasma in the early stage of the disease rather than waiting to go a patient for a CRS or the cytokine storm and then start convalescent plasma. Now, clinical use of convalescent plasma, it is not a new therapeutic. In the past, even 100 years back, when you have a Spanish influenza, the people have used convalescent plasma. At that time, there was no such technical advancement for the convalescent plasma. But even that time, the impact of convalescent plasma was huge. And if you look at the paper, they have shown the 50% survival in those patients who has received convalescent plasma. Recently, even in the African Ebola outbreak, people have used convalescent plasma, and the recent outbreak of the MERS COVID and the SARS-CoV-1, H1N1, all these have used convalescent plasma as emergency treatment, and they have found a positive result in these epidemics. Now, coming to the COVID-19 patient, the early experiences from the China, Wuhan, and here the 5 severely ill patients with the coronavirus COVID-19 treated in Shenzhen People Hospital of China, and all patients had severe respiratory failure. One patient also on the ECMO. The patient received convalescent plasma around hospital day 20. Antiviral treatment, primarily lopinavir and ritonavir, were given to the patient, and they found the clinical status of all patients has improved approximately 1 week after the transfusion. And this was probably the first published article in March 27 in JAMA, which has shown that although it was an anecdotal report or case series, but it opens the door of the convalescent plasma in patients of COVID-19. And after that, many countries and started using convalescent plasma in such situation, and there was no randomized controlled trial. At least the first randomized controlled trial was published in the June, and it was also published in JAMA. And the topic, if you look at here, the effect of convalescent plasma therapy in time to clinical improvement in patients with severe life-threatening COVID-19. Going to detail to this trial, it was stopped because the number of patients was not sufficient to go for a clear-cut evidence that convalescent plasma is effective in COVID-19 patients. And the interpretation was limited by early termination of the trial. It was not possible to continue the trial in China because by the time the trial was going on, the cases in the China were at the ending. So the final result was unfortunately not very conclusive. So the editors came to the conclusion that interpretation is limited by early termination of the trial. However, they found some benefit in terms of the improvement in the patient's clinical condition and survival, those who has treated with convalescent plasma. Now, Indian scenario. Most of the Indian hospitals and the states are in this pandemic going to according to the ICMR guidelines. And in the convalescent plasma, the ICMR guidelines tells that the convalescent plasma is off-label, may be considered in patients with moderate disease who are not improving, oxygen requirement is progressively increasing despite use of steroids. Patient prerequisites while considering convalescent plasma includes that the patient and the doses is variable ranging from 4 to 13 ml per kg. What we are using the 200 ml single dose to those patients who have got indications for convalescent plasma. So mostly our guidelines or our hospitals protocol are based on the ICMR guidelines. We'll go further to the ICMR guidelines, and if we look at the guidelines at trial, the ICMR has started trial on 6th May, and this trial is titled a phase 2 open-label randomized controlled trial to assess the safety and efficacy of convalescent plasma to limit the COVID-19 associated complications in moderate disease. This is called the PLACID trial. This PLACID trial is going in more than 90 hospitals at present, and we are waiting for the trial results. So far, ICMR has not published the trial results, and it is the indications for the patient with moderate COVID-19 illness will be randomly assigned to receive either a convalescent plasma, 226 participants, or the standard care, the same number of participants. The primary outcome of this trial they have considered is the prevention of illness from progressive to severe form and avoidance of death from the all cause 28 days after the plasma infusion. The secondary outcome, resolution of the symptoms, reduction in the hospital stay, and the respiratory support reduction. Now, if you look at the inclusion criteria for the PLACID trial, they have found age than more than 18 years, patient with RT-PCR confirmed COVID-19 illness, and has any of the two, the pressure of oxygen in patient arterial blood VO to FiO2 ratio is 200 to 300, and respiratory rate more than 24, and the saturation less than 93% or lower. And the patient will must have availability of the matched donor plasma at the point of enrollment. So if you look at carefully the inclusion criteria, it's all that the moderate disease. It's not a severe or critical disease. So basically, ICMR is this PLACID trial to assess the moderate disease effect of plasma. Now they have exclusion criteria also. The pregnant and breastfeeding women, known hypersensitivity to that, has been recipient of blood immunoglobulin in last 30 days. The critically in patient PF ratio less than 200 and patient is shocked. If you look at these two category of patients are out or they are in the exclusion criteria. And participating in any other clinical trial, obvious clinical status including infusion of blood product. So these are the exclusion criteria, and if we carefully if you look, the ICMR has not included the severe form or the critical patient with COVID-19. Now, who are the donors? Must be 18 years of age, males or nulliparous female with more than 55% of 55 kg. Prior diagnosis documented by RT-PCR with symptomatic disease with at least fever and cough. Complete resolution of symptom at least 28 days prior to donation, or a complete resolution of symptom or at least 14 days prior to donation, and 2 negative RT-PCR of COVID-19 nasopharyngeal swab 24 hours apart. In addition, donor eligibility criteria for whole blood donation. So, besides the whole blood donation criteria, these criteria should be fulfilled by an eligible donor for the convalescent plasma. Now, these are the essentials for the transfusion. You must fulfill the criteria also. The standard transfusion FFP should be followed with a special care to monitor this patient during the post 24-hour transfusions. Use blood transfusion sets. An ABO compatible plasma bag of approximately 200 ml will be issued, maintaining all the blood bank records after point at 37 degrees Celsius. These are the part of the PLACID trials protocol, which we are also following when we are trying to infuse the plasma in our patients. Now, coming to our experience, as now we have collected about 50 samples of the convalescent plasma and have collected, and 200 to 400 ml plasma were collected in each donation. In fact, one person can donate up to 400 ml. If nothing is going to happen to the patient if we agree, but usually we collect 200 ml and we ask if he agree for giving 400 ml, then we already collect to the patient. And complete resolution of symptom at least 14 days prior to donation, and 2 negative RT-PCR for COVID-19 and nasopharyngeal swab 24 hours. So once the patient has recovered and 14 days has lapsed and 2 negative RT-PCR after 24 hours, these are the patients who can give the plasma. Remember, the HB is also important, and we have said the patient must have hemoglobin of 10 to give for the blood donation. Now coming to the antibody titer posture. Now most of the trial which is done in the China, they have checked the titer, and they have checked the titer up to 640. Unfortunately, in India and most of the world, there's no way we can check the antibody titer for the convalescent plasma. So what we are doing, we are just qualitatively checking the antibody titer, and if the patient has got the antibody, then the patient is getting fit to be donated for the convalescent plasma. So far, we have given 30 COVID-19 patients in the standard of care, and we have not found any adverse event like trolley and other things. Now, coming to the outcome, we have not analyzed systematically, but what we have found in patients who has received in the early part of the disease, those who are just getting to progress to the severe form, they have got some reversal of the clinical symptoms, particularly reversal of the respiratory distress and the oxygen saturation. Now, at this stage, for us also, it is very difficult to say that what is the impact of the plasma on the later stage. Many patients we are facing coming to the later stage to the hospital, and because of the patient request, we are bound to give convalescent plasma in such patients. And to be frank, we have not found very, you can say, good results in such patients who has gone into the cytokine storm or has gone into later stage like ARDS and requiring mechanical ventilation. So what we have learned from our experience is that if at all the convalescent plasma has to be used, it has to be used within 10 to 14 days of the illness. And in the early part of the illness, once the saturation is started decreasing and the patients will become tachypneic requiring high frequency, high flow nasal cannula or the requiring non-invasive ventilation, if I have to go in more than 60%, this is a time when we should choose the convalescent plasma in such cases. Now, what are the challenges of the convalescent plasma? It is very important. The access to the recovered patient and convincing them to donate their plasma. This is the point. Despite so many patients has recovered, despite so many new channels and so many advertisements, nobody is coming forward to donate the plasma. Reason: people think that once they donate the plasma, their immunity is going down, and their fighting the corona is going down. So this is one of the hindrance, and we can say that, and one of the challenges that we can face in collecting the plasma. Now, sufficient quantities and high antibody titers so that the enough people can benefit from the same. We do not have any measure of the antibody titer, and it is one of the limitations for the convalescent plasma. The blood from plasma donors will have undergone testing for the infectious agent and blood group compatibility with the recipients. All this will require a massive coordination between the medical personnel and the agreed donor, which is very difficult to maintain. Now, what are the limitations of the convalescent plasma therapy? Ineffective in regulating the cytokine storm syndrome. Once the patient has gone into hypertension, once the patient has requiring vasopressors, once the patient has gone to severe ARDS, very high IL-6, and I tell you, if the patient has got a high D dimer and high fibrinogen, these are not the patient for the convalescent plasma. So a cytokine storm is relatively a contraindication to use a convalescent plasma. Lack of gold standard for the evidence-based medicine, because what we are trying to find out the convalescent plasma, when one hand and other hand many treatments. So far, there is no gold standard for management of COVID-19. So this is one of the limiting factors to assess or to judge the impact of the convalescent plasma on the mortality or the clinical condition of the patient. Third, as I told, the sufficient titer of neutralizing antibody cannot be guaranteed because we are not measuring quantitatively measuring the titer. In fact, the patient who received convalescent plasma in MERS and SARS and they have a convalescent, they have a titer of up to 640, and this we are not measuring in our patient or our donors. And of course, because it is a plasma, it is effective, so the transformative inverse events are we have to accept that when patient might develop all these transfusion-related lung injury and the other adverse effects. The other challenge is very important. Look at some of the news headlines that the plasma therapy saved my life. This says the Delhi Health Minister after beating the COVID-19. The same day, the plasma therapy no magic bullet against COVID-19, the medical experts. These are the special challenge for the treating hospitals because we are dealing with the patient and patient relatives. Now the patient relatives comes to you in a very early stage also and they say that, okay, please transfuse plasma to my patients. Some of the relatives will come, the patient is in a dying condition, and they will also tell you that please transfuse plasma to our patient. They are going by these reports. Many patients, if you feel that patient requires plasma and they don't have donor, they will give you this excuse that okay, because now the people are going by net and Google, and they are reviewing everything. So for experts, you have to be very cautious when you are transfusing the plasma. We should follow strictly the ICMR guidelines and use plasma as an emergency basis in moderate patients or moderate severely patients. And we have to face all the challenges which we are facing day-to-day life in our hospitals. Now to conclude, the convalescent plasma has the potential to provide the immediate promising treatment options because at present there's no definitive treatment and it is readily available. The treatment appears to be helpful until definitive and effective treatment are found. The effective convalescent plasma should contain a high titer specific antibody. This is our limitations. We are not measuring the titer. It is not possible to measure the titer. So we are just doing a qualitative antibody test. And if the antibody is present, then we are taking the patient for the plasma. A large scale screening is needed for inclusion a large number of COVID-19 patients. This is very important because we have to make sure that a lot of screening to be done from the donor to find out many donors, at least 50% donors are unfit because they are comorbid conditions, because they are not fit for donations. So these are they are also having some infectious like hepatitis B and other positivity. So it is getting convalescent plasma is not easy. Recently in Delhi, the plasma bank is open and now it might ease our task to get the plasma in the needy patients. The most important is further evaluation of the efficacy and safety of convalescent plasma in the patients should be carried out in the carefully designed RCT. So far, the only one RCT which has the limited number is the stopped prematurely. The other RCT, the PLACID Trial, we are waiting. The New York also they are conducting some RCT, but the results are not available. So, meanwhile, we can use the convalescent plasma in emergency basis or in the off-label drug, but strictly under the guidelines or under the ICMR guidelines. Thank you for your patience listening and happy to answer questions.
Thank you, sir. Thank you for very elaborative and very informative presentations. There was a lot of questions in my mind, and almost all the questions have been answered. Sir, I would like to just know one or two things. As you have rightly said that there was a scarcity of plasma donations, and the current recommendations is around 4 to 14 mils per kg, so it's around 200 ml which will suffice. So, do you recommend to take a 400 mils of plasma and to divide it into the two bags and can be transfused in the two different patients?
We are doing that.
Oh, yeah.
If the donor agrees to give 400 ml, then we are collecting in two bags.
Right, sir.
And these can be used for two patients.
Okay, thank you, sir. Sir, another thing, as we just cannot measure the quantitative antibody titer. So, what would be the base time after the negative, after the first COVID positivity? What would be the base time so that we can expect that there will be a highest titer of the antibody? It would be around 4 weeks from the first positivity or 3 weeks?
See, ideally, the best time would be the 28 days for fourth week.
4 weeks.
From the first positivity. Yes.
Yeah. Thank you, sir. So,
Sir, we have Dr. Shourav Madi online. He wants to ask a question.
Yes.
yeah, please.
Yes, Dr. Madi.
Can we use the antiviral and steroid both with the convalescent plasma along with convalescent plasma, because it is probably the antigen neutralizing agent. The other part, if there is any cytokine storm or that part is taken by the steroid. So can we use the antiviral, convalescent plasma and steroid both together?
Actually, we are using both together. We are not using convalescent plasma alone because it is we are using out of the trial. Okay, even in the trial are the convalescent plasma and the standard treatment. So they are using standard treatment as convalescent plasma and the standard treatment. So even in the trial, it is as in the combination with the standard.
Okay. And another question: how we can choose the patient for the, as we are not doing the antibody titer,
Yes.
and we are doing it qualitatively. If there any chance that this qualitative method can decrease the efficacy of the convalescent plasma?
We do not know. We do not know whether the titer is 1:80 or 1:160 or 1:640. We do not know. But what we have found that I have talked to my blood bank people also, and they also do not have any method to find out exactly what is the titer. But once they are they are detecting the titer, it is most probably more than 1:80. Okay. So, what ICMR and other people recommend, there's a recent recommendation, if you get a titer 1:640 is the best.
640.
Yes, but this is very high titer. And I don't know in India anybody has done this because it was used in China and Hong Kong during the time of SARS and MERS. And they have found a very, very high impact on the mortality, but the titer was very high.
Okay. Thank you, sir.
Okay, thank you, Dr. Maji. There are one or two different questions that has come into the question box. So there is a questions for Dr. Asif. Ma'am, Chunki ma'am has actually asked you your experience with the tocilizumab along with your antiviral drugs.
Yeah, actually, we see that when there are patient admitted with a high oxygen requirement, we send the IL-6, and if the IL-6 is more than 10 times of the normal value, then there is this group of patient is the high risk for developing the cytokine storm. So we use the tocilizumab along with the low dose steroid, and obviously with the remdesivir. And we have found recently that by this treatment we are able to prevent the cytotoxin storm, and that is the most important indication for preventing the cytotoxin storm is the oxygen requirement reduce and the hemodynamics improvement and the recovery of the happy hypoxia.
Right. Okay. Thank you, Asif. Sir, you have a question. There is a very interesting question. Dr. Mondol has asked for you. Sir, is it possible to collect the plasma from the community from the people who are antibody positive, never tested RT-PCR as they were asymptomatic?
Sorry, I could tell me.
Sir, is it possible to collect plasma from the community from the people who are antibody positive? They have never tested for positive the COVID because they were asymptomatic.
See, uh, the, 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 the limiting line is physiologically, we know that those patients who are asymptomatic, their titer seems to be very low. So,
Yes.
in asymptomatic patients, the titer is very good because their viral load is very low, so the antibody titer is also very low. That's why the guideline says that in a symptomatic patient who has recovered, they are supposed to have a high titer and their plasma is very, very good. That's why if you are taking from the community with antibody positive, it's okay. But again, the question mark of yes, if you can measure the titer, that is good. Maybe after 1 month, you'll be able to measure the titer.
Thank you, sir. Sir, another few questions that has come that was not related to our today's topic, but the ACQS prophylaxis related. Dr. Chandrapriya has asked whether we should continue the prophylaxis beyond the 7 weeks. Yes, there is no recommendation as such to continue beyond 7 weeks, but personally said with the healthcare professions, we are still taking weekly. So if there is no contraindication, no harm of taking it, but there is no hard data or something to support as well. Okay, so I think, sir, it's a very interesting and elaborative and very knowledge sharing event that we are going through. And I would like Dr. Ahsan Ahmed, yes, Ahsan has joined. So I request Dr. Ahsan to conclude the sessions and to give the vote of thanks.
Thank you all the speakers, Dr. Amitabh, Dr. Vinod Singh sir, Dr. Atif Iqbal. Thank you, Dr. Amitabh, for conducting the session very nicely, and Dr. Singh for highlighting all the things about the plasma therapy, convalescent plasma therapy, and Dr. Atif also very brilliantly explained everything. Thanks to HCG Forum and Jayati for organizing such a nice thing, and Dr. Pajaj, ISCCM Kolkata branch for conducting this very nice program on a Sunday afternoon. So I think many people will be highlighted by this updated knowledge about this system. So thank you all.
Thank you very much.
Thank you.
Thank you, Jyoti.
Thank you, sir. Thank you, everyone.
Yeah, good night,
Okay,
sir.
thank you, Dr. Binod, for
Thank you.
sparing time.
Thank you,
Dr.
Dr.
Asif, Amitabh, Ahsan.